Hello, everyone. Thank you all for joining us. Like Dr. Michelle Kelly was just speaking about, it's so great to see so many people in different time zones, different countries. Some of you joining us very early. Thanks, Varsovia, for being here with me. And some of us joining very late. So thank you all. Before we get started, I just want to cover some nuts and bolts before we start presenting and getting away with information. For people obtaining BACB CEUs, there will be 2 code words that we have sprinkled in to this presentation. So if you don't yet have a pen and a pad of paper, something to write them down, or the ability to remember them, go and do that now so that when we get to them, you can get your CEUs. And at the end of this presentation, if you automatically close, I was told that it will all pop up for you as well, but Dr. Michelle Kelly will also be sending out links to a survey and the ability to enter those codes so that you can get your CEU credits. Okay, I think that's everything I was supposed to cover. We'll talk about some features of WebEx as well. Some of you are getting familiar with the chat feature. Please do comment and chat away. I will do my best with all of these windows, Varsovia as well, to try to get to the chat feature. I'll talk about that again in just a second. But you all are hopefully joining us to learn a little bit more about the scope of practice and competency in the assessment and treatment of pediatric feeding disorders. Specifically, we're going to talk about it from a behavior analytic lens. So what is the scope and practice of our particular discipline, but we have sprinkled in other areas that are involved. So if you are in other disciplines like speech and language or occupational therapy or dietetics or anything like that, there is probably information hopefully that's useful for you all as well. So let's get started. First, I would love to thank Dr. Michelle Kelly, especially for inviting us to have the opportunity to present with you all today. The Emirates College for Advanced Education and the ABA UAE program. And I just am so looking back at some of these webinars that have been conducted, I don't know how Dr. Kelly does all of this, but if you haven't joined previously for other talks, they're quite amazing. It's so great to see the scope of what is happening here, and I will definitely be joining for future talks. I'd also like to thank somebody who is attending as well, Dr. Sarah Mead Jaspers. She is a catalyst that got me connected with Dr. Michelle Kelly. So this probably couldn't be happening without some of her networking, as you've probably also seen her typing away in the chat. So before we do get kind of into some of the more informational components and discussion about scope of practice, figured we would just talk to you a little bit about who we are, who the presenters are, who's delivering this information, what our backgrounds are, so that you kind of can get context for where we're approaching some of our thought processes. So I'm Jonathan. I received my master's at the California State University in Sacramento under the advisement of Dr. Becky Penrod. And that's where I started doing a lot of my early work in pediatric feeding problems, mostly in the area of food selectivity and for individuals with a variety of developmental disabilities and those individuals with autism spectrum disorder. And then I continued my education at the University of Florida under the advisement of Dr. Tim Bulmer. You'll see his name pop up again when Varsovia starts talking. Where I continued my work within early intervention clinics and inpatient, outpatient types of models for the treatment of rigid and repetitive behavior, again, namely food selectivity. I'm currently an assistant professor at the Florida Institute of Technology. You can find hopefully my information on the website. I'm going to, at the very end, also link our emails. So in case you need to get a hold of us for any other reasons or continuing your growth in competency building. So I've been here, I'm new to FIT. I just started this semester and getting kind of situated, but hopefully we'll be here quite long term. The areas of interest that I have as a researcher as well as a clinician practitioner are in the areas of assessment and treatment of rigid and inflexible behavior, most namely highly selective eating patterns exhibited by children and adolescents.
Well, hi everybody, and thank you for being here. My name is Varsovia Hernández. I'm from Mexico, and I did my PhD at the National Autonomous University of Mexico, and then I continued my studies at University of Florida with Dr. Timothy Ballmer, and actually that's where I met Jonathan. Then I came back to Mexico, and now I am a researcher at Universidad Veracruzana. And I work on two main lines of research. The first one, obviously, about pediatric feeding problems. And the second one, it's about motivational operations. So I conducted my PhD on experimental analysis of behavior. And then because I wanted to have that applied side and have the practice, and in Mexico, we don't have a lot of opportunities for that. So that's why I moved to Florida and I met Jonathan, and well, the rest I think that it's history.
So we're going to just chat a little bit about that history as well, just so you can kind of see why this is important. We're going to connect it back to competency. We are all learning and growing, and even if we are experts in an area, we still have to stay up to date. And that's going to be a common thread with this conversation today. So Varsovia and I met, of course, in this dark, windowless building here, which some of you in the audience are familiar with, the psych building at the University of Florida. And together we started learning and growing, and we've continued that for quite some number of years now. I don't know if we should really say how many, but we've had a long history of growing together in a variety of ways. And fortunately, even through a pandemic and hopefully coming out of this soon, we will be able to see each other in person again. But some pictures there on the left-hand side, you see us at various different conferences. That top one with the umbrella is Windy Chicago for ABAI. And below, I was invited, Varsovia invited me to Mexico to talk on feeding problems. So that's me doing some of my international work, which I love. The picture next to it, of course, is right after that talk where she took me out to some authentic Mexican cuisine. And that was some joyous occasion. And then again, at additional conferences, I believe that one is Denver, I believe. For another ABAI. So what I'm going to do now is I'm going to post in the chat here a link so that we can get to know you a little bit. I know that some of you have entered some information into as you were registering, but we'd really like to just know who's here today. So I'm going to post this now, and let's see if this works. You should see some questions that come up when you follow that link. You should be able to select multiple options here. And I really am going to credit my colleague, Dr. Sarah Mead Jaspers, for a previous talk that she gave for the same group. You can see her recording if you follow that link that Dr. Kelly gave. But she used very similar questions, and I thought it was genius to kind of see how we can tailor some of our conversations moving forward today. So you should see, what is your role in the delivery of ABA services? So are you a consumer? Are you a parent, a behavioral therapist, a student in some capacity, a certified individual, so an RBT, a BCABA, a BCBA, or an allied service professional, so speech or occupational therapy, or other? Ooh, I see some responses already coming in. So also how to rate your experience with feeding problems. So do you feel like you're a complete novice? I have some kind of definitions there for you as well. So you're not quite sure what a feeding problem is, or all the way to an expert that you are working in this area, designing feeding related research or incorporating those research into clinical practice. And then because, oh, that's lovely. I see a BCBA SLP combo. So I'm glad, hopefully you were able to check multiple boxes. Also with your rating your competency level. So this is all about building competency. Again, we're going to network together. So if you want to share your emails with people or so forth, hopefully people can get connected. That BCBA SLB combo is amazing. I would love to connect with you at some point in the future. So are you a novice to an expert in terms of how you feel in terms of competency? All right, so wonderful. RBTs.
BCBA from Italy.
All right, so let's see what's coming up here. So you can all see these, I think, right?
Yeah.
Perfect. We have a lot of BCBAs, which makes sense because you are all hopefully here to get some free CEUs. That's wonderful. We're seeing some spread here, some BCBA-Ds, and then some apparent, which is great. I know many of you even are probably speaking with parents about how concerned they are with their child's feeding problems or trying to get them to eat healthier diets. Some others, wonderful. And then a range of experiences in feeding problems here. So mostly at that beginner level, it's great to see that people are at least reading up on feeding problems. And then some people who are very much experts in this field. So please, experts, chime in if you would like to in the chat box. I'm going to try to gauge some of our conversations to hit all of these levels, really. So hopefully there's something here for you all. Experts don't get bored with me as I try to reach some of our more novice beginner folks, and then vice versa. If we try to extend to more complex issues, beginners don't get lost. You'll get there eventually as you build your own competency. And then rating competencies, looks like many of you, even though you said you were beginners, advanced beginners, it looks like you are still very unsure of yourselves. So that is okay. We'll hopefully build some competence a little bit here, or at least confidence in moving forward. All right. We'll take a peek back at that later again. All right. All right, thank you all for filling that out. I'm going to pass it over to Varsovia, and we'll go back and forth a little bit here.
Well, thank you, Jonathan, and thank you everybody again. So I will mention our objectives for this webinar. So in the first place, we will list type of assessment and treatment for pediatric feeding disorders. Then we will identify the scope of practice and competence of behavior analysts in the assessment and treatment of pediatric feeding disorders. We will identify how training and resources may impact one's ability to implement assessment or treatment for feeding problems. And number 4, we will identify areas of competency and further training in the assessment and treatment of pediatric feeding disorders.
So before we get to our disclaimer, again, I see lots of people chatting. That's wonderful. Varsovia and I will try to either vocally comment on if you have questions that pop up. Yeah, I just got a question. Yes, it's possible. I can, if you email me, my email's at the very end. I'm very happy to send you over a PDF version of this PowerPoint. So please chat. If we miss your question for some reason, we should have ample time at the end to have some conversations as well. So please do that, but we'll try to also stay on top of the chat. Just a disclaimer here. This is a short-ish presentation. Some of you may feel like it's long, but it's relatively short in terms of being able to build somebody's competence. So we are not assessing your all's competence in being able to assess and treat pediatric feeding problems. So we are not going to provide that training necessarily in this format, and we'll see why that will be difficult to do in this format. But again, we do invite you to have real discussions. I want this to be more of a not lecture-esque, but more of a casual conversation about where we're at in terms of our treatment approaches and how we can move forward as well. And if you're in allied disciplines, how we can maybe work together too. Again, just as a disclaimer, I'm going to be moving back and forth between some of those levels of expertise as well. So hopefully there's something here for everyone. So just as a roadmap for you all, so you can kind of time ourselves and you don't get lost in our presentation, we're going to just give a very brief overview of what pediatric feeding problems are. We're going to go into then the scope of practice and focus on not only some of the other disciplines, excuse me, outside of behavior analysis, but especially how there's overlap and how those individuals and disciplines should be involved in the assessment and treatment of pediatric feeding problems, but has also spent some time on the behavior analytics side of scope of practice. We're then going to move into a discussion of the overarching sequence of steps for providing intervention. So we do hope to provide some brief overview of what different types of assessment and treatment strategies could look like. And then moving into this kind of what I see as the second half of our presentation, which is the ethical considerations and focus on competency. Building competency is the second bullet there. So how do we assess our own competency, and how do we, from there, provide ourselves information for how to achieve and build additional competencies in different kind of areas.
Okay, so let's begin with discussing what pediatric feeding disorders are. So feeding problems and disorders are identified when an individual is unable or refuses to eat or drink a sufficient quantity or variety of food to maintain proper growth or nutrition. So it is important to notice that a lot of children at some point present some kind of food refusal behavior. For example, sometimes they may reject to eat some vegetables or some particular types of meat. But in this case, what is important to highlight is that these problems affect their development. While picky eating is something that most kids will outgrow, usually by the age of 6, feeding problems do not fade away while children age. So this is important to keep in mind.
And it's interesting, if you're reading some of the multidisciplinary literature, is we still don't, I think, have an agreed upon kind of definition across some of the disciplines as well. So I think from a behavior analytic lens, and I think from some of the overarching kind of combinations with other disciplines, here, however that feeding problem looks, it's affecting growth and nutrition. And that I think hopefully we all can agree is not a great thing. We'll see some side effects that if you engage in those behaviors, why that might be really problematic.
So the prevalence of these problems is actually very high. Although we have different reports, in general terms, it is around 45% in typically developing children and up to 80% in individuals with disability. And this is important to know because it means that it's very likely that you are or you will be confronted with this kind of problems in your practice.
We kind of put that a little bit in our abstract as well. So especially the BCBAs out there who are doing kind of general applications to, let's say, autism treatment in early intervention clinics, you are probably confronted with caregivers asking a lot about diet, or you're seeing some of the rigid and repetitive behavior manifest in kind of unhealthy eating habits or restricting eating in a variety of ways. So if you look at those two pie charts there, the blue area especially, you're seeing on the left-hand side, 45% of typically developing children, and that grows to 80% or upwards of 80% for individuals with disabilities, including autism. And so that particular population, it has just a higher risk of having some form of feeding problem. And as Varsovia said, that these problems for that particular population don't just go away, like maybe the typically developing children. It should also be noted that even with typically developing children, they're probably just responding to naturalistic interventions over time. And so things that caregivers or that are providing them in kind of ongoing development and meals that they're providing them. And then, of course, when they get to school age, they may be influenced by their peers in social contexts to try new foods or so forth.
Yes, so feeding problems can go on a really broad range of severity, from total food refusal to mild cases of food selectivity. And the more severe cases are the ones with total food refusal, which are kids that do not consume any food by mouth and are in risk of severe weight loss and malnutrition. For them, in some cases, different medical procedures have to be implemented to ensure that they meet their caloric needs. For example, with the insertion of some kind of feeding tubes.
Yeah, there's a question in the chat about whether or not this is an increase in cases or just better identification of feeding issues. So those are two separate populations. The range of prevalence really depends on the literature that I'm just going to go back really fast. The literature that you are picking up and reading. So there's a range there, and we've highlighted some of the more kind of consistent ranges. Those are, and some of the higher ones. So depending on how that particular study and research defines a feeding problem, may contribute to some of that variability that you see in terms of prevalence. So for example, we even talked about how defining a feeding problem might be really challenging, and especially across discipline when you're looking at the multidisciplinary work or that work being conducted in its own kind of area. Um, we'll see in a little bit that some of these different types of problems, if you're looking at from a structural approach or a topographical approach, may be hard to determine whether or not that is included in some of the research or not included in some of the research. So for example, pica or eating inedible objects, we'll talk about in just a second, whether that's included in some of these research statistics and so forth is sometimes very hard to pinpoint and pull out from how they've defined these particular problems. So for example, a lot of the typically developing literature or research on typically developing children and feeding problems tend to be very broad and tend to be a lot of survey research on whether or not an individual has had a feeding problem at any point within their kind of current lifetime, even though they may not currently have one anymore. Whereas most of the research on individuals with disabilities is focused on current feeding problems and whether or not they do currently have one. So it's kind of even hard, I would say, to compare some of those statistics as well, and why I really highlight or like to highlight in my presentations that many individuals who are typically developing will kind of quote unquote grow out of those problems, or the problem will improve over time without any kind of formalized intervention. I think we're here, right? Did you finish Varsovia?
Yes.
Okay, perfect. So if any of you are familiar with tube dependence, those types of tubes may look very different as well and are named basically where it enters the body and it ends within the digestive tract. So for example, a nasogastric tube would enter the nose and end in the stomach. So there's a variety of different forms that you may come across. And this is starting to highlight some of those medical approaches to sustaining growth that we'll touch on, and why we need to collaborate with medical professionals in this particular domain. So let's move from food refusal to food selectivity. There's a variety of different forms of food selectivity, and really the way that I like to look at food selectivity is there's some variable with respects to the food or the mealtime environment that is controlling whether or not, or influencing whether or not somebody is willing or not willing to consume that particular food. So that might be in the type of food, the texture of the food, particular brands, smell, temperature, presentation. Name the variable, it doesn't matter. Something is influencing whether or not they eat that food at that given moment. And so I'll highlight some type and texture types of assessment-esque stuff that we could do here. So if you were selective by type, we have 4 different foods here in those rows, starting with rice and going down to, I think it's carrot, salmon, and broccoli. And so if you were type selective, you would be willing to eat one of those foods, let's say. Let's say you're willing to eat the rice, but you're not willing to eat the 3 other foods. And it wouldn't matter any other variable, really. So if you presented that at a pureed texture, which is that left-hand side, that column going down, and a tabletop texture all the way to the right there, it wouldn't matter what you presented rice at. I would eat it if I was type selective. I just wouldn't eat the other foods. So this is very indicative of kids, for example, who refuse to eat fruits and vegetables. They are selective by type. They're eating other categories of food, but really, really restricting their diets in that sense. If you were texture selective, then you might eat one of those columns. So I might eat at that pureed texture, but anytime that texture gets more coarse or dense, or there's now various size particles in that puree, moving towards that more solid texture, then I might start engaging in problem behavior in some way, shape, or form. I might start expelling the food, or maybe even coughing, gagging, and vomiting, and so forth. Thank you, Dr. Mead Jaspers. We kind of talked a little bit about the definition of a feeding problem. So at what point does food selectivity become an issue that then requires intervention? Now, this is difficult because sometimes, just like any problem behavior area, what warrants intervention? And so here, I would argue that if, from a sustainability standpoint, from a growth and development standpoint, if that is impacted in any way, it likely does warrant an intervention. So you might just, let's say, not like vegetables. Very common problem for many, many kids, and maybe many of you in the audience as well, right? We'll talk about some intervention approaches that you might even start for yourself. Now, that's long-term not going to be the best thing in terms of a nutritional outcome. And so you may want to get medical professionals or dietitians involved with what is really being impacted at that point in time. Luckily, as adults, we have a lot of other different strategies that we can use for our own selves in managing healthy diet, whether that be supplements or, some of the interventions that I'm going to talk about and trying, so that our health and well-being is not as impacted and making those choices for ourselves. But for kids, that likely is not necessarily happening. Now, the more severe that selective kind of habit becomes, that is then going to, of course, warrant not necessarily whether we intervene or not. Yes, we will intervene, but may warrant to what extent we intervene. So we'll talk about more kind of quote unquote intrusive interventions or more drastic interventions so that we can put that individual onto a healthier path of growth and development. Yeah. So you may see generally, you see within the behavior analytic literature, if a kid is eating from fruit, vegetable, protein, starch, those four categories, if they're eating about 4 items from each category, generally they are pretty good in terms of variety. From my standpoint, variety is not done there. I mean, you can probably name 4 from each of those categories that you eat and then pretend like you're restricting the rest of the foods from there. And that's probably not still the best diet. It just doesn't warrant maybe some of those more intrusive interventions. So we may still move forward with some form of exposure or feeding protocols or maybe a reinforcement paradigm. But we are probably going to not necessarily do escape extinction or something like that necessarily for a selective eater at that level. But somebody who's restricting, let's say, 4 or fewer from any one category would be somebody that would at least need to get some assessment done, let's say that way. Thanks for that question. All right, let's move into some other areas that you may come across in terms of impacting feeding. And this is in terms of any physical limitation surrounding eating, whether that's due to genetic or physical abnormalities or a lack of experience, let's say, could impact whether or not you are eating or eating in the ways that is deemed socially accepted by your culture that you're currently in. So, for example, cleft palate is going to have a lot of issues, at least in early development prior to surgeries, with experience with lip closure or mastication, chewing, moving and lateralizing your tongue. So it makes sense that somebody who has that prior history is going to probably present with some early needs to overcome some of those experience limitations. Now, many of these different types of problems could be for fine motor ability, for example, grasping and picking up foods or using utensils, but also oral motor ability. I mentioned, lip closure, tongue lateralization, chewing and swallowing properly, and so forth.
Yeah, here it's important also to mention, Jonathan, that prematurity is highly correlated with feeding problems, and this is likely due to a lack of early experience in developing those kind of skills that are needed.
Absolutely. We can kind of think about hypothetical examples where, depending on some of those medical problems that the child may have encountered at birth, if you're premature, you may have hospital stays for, let's say, a day to maybe several months, right? Where, that experience may restrict, for example, early feeding and how that looks, and then that may impact when we do get some of those medical problems taken care of, what those feeding problems kind of look like for sure.
Yeah, I think that sometimes we don't realize how many muscles and coordination requires to eat that just one bite of food.
Yeah,
But actually, it's like a very complex process.
it's a lot. And this is my early shout out to our SLP OT friends in the audience that this is where, those individuals, those disciplines really, really do matter. And we'll bring those individuals up again.
Well, now, besides total food refusal and food selectivity, there are also other types of problems. For example, we can see some kids who engage in rapid eating or eating too quickly, which is a problem since it has been linked to a high risk of choking. Sometimes we also have kids that eat too much, which can also cause some gastrointestinal problems. We have seen kids who engage in pica, which is the ingestion of non-nutritive substances. For example, eating little stones or dust or picking things from the ground and then biting those things. We can see some cases with rumination, which is the regurgitation of food following consumption. And we can also have some messy eating kids. So in this case, eating requires additional supervision.
So we're not going to cover a lot of the assessment and treatment of these particular topographies of feeding problems that involve either oral motor, ability or consumption of things, or, digestive kind of things that are going on there. But it is kind of nice to note that those problems do exist. And if you are interested in feeding, that these types of things may come up in your lit searches as you're looking for various different types of assessments and treatments for those problems.
Yes, so typically it's not just insufficient quantity and variety we're concerned with. And I think that this kind of relates a little to Sarah's question. So those type of problems often occur with problem behavior when non-preferred foods are presented. For example, we can see some kids who engage in aggression, tantrums, for example, when they cry and scream. We have seen some kids with self-injurious behavior, with negative vocalizations, for example, kids who say things like, this is disgusting, I don't want to eat that. Some kids engage in disruption, for example, throwing food and utensils. And also we have seen some kids that run away from the table, who engage in expulsion. This is spiting out the accepted bite of food. Packing, which is also pocketing or holding the accepted food in the mouth for lengthy periods of time. And gagging or vomiting. So individuals who do not consume enough or who do not eat a wide variety or well-balanced diet are an increased risk for a number of health, developmental, and also social impairments, including but not limited to weight loss, growth retardation, obesity, malnourishment, lethargy, impaired intellectual development, impaired biological functioning, and in some extreme cases, even death.
Yeah, so this again, back to, Sarah, your question, and why it's so important for this to be a multidisciplinary approach to the assessment and treatment of feeding problems. As a behavior analyst, I have very little experience and competence in how feeding is affecting some of these maybe measures. Of course, I've gotten pretty good with measuring weight and things like that of individuals. But having somebody who that is really their primary area is really important. And to note whether or not current diet does have some more of those drastic long-term problems. So, for example, we're seeing, rises in things like scurvy, where it's like we have not seen that in, a really, really long time, related to various different types of nutritional deficits and things like that, that especially individuals with, for example, autism or related disabilities are now highly susceptible to because of their restricted diets.
Well, as this picture shows, families with children who engage in food refusal report higher family stress than those families with children who eat a wide variety without problems. Also, having to deal with some of the feeding problems we just mentioned also hinders the possibility to establish and practice adequate social behavior for their children and their families. Sometimes families, they don't want to go out to have dinner because of these problems that they are seeing, or sometimes they stop going out with the family, friends, etc.
I think Varsovia and I have seen the types of families that come to us or the clinics that we're working within, problem behavior or lack of communication skills for the clients that we see seem to be kind of the number one priorities for families. And then once we start to see, a little bit of decreasing in problem behavior or increasing in communication, we have effective interventions in place for that. All of a sudden, their top priority becomes feeding. And I want my kid to be healthier. I want them to not engage in inappropriate mealtime behavior. I'm done cooking 7 different meals at once and being a short order cook for my family. How can we impact this particular problem? And it makes sense that any of you who have children in the audience or have worked with cooking for individuals, this can be really, really challenging when you have so many different kind of preferences for what that meal might look like. So let's move a little bit into scope of practice for pediatric feeding disorders. And I'm going to talk about where some of these disciplines kind of overlap or what their expertise are, and why the kind of proposed model of assessment, especially the medical side of things prior to a behavioral intervention, might be really important for us as behavior analysts. And we should acknowledge that feeding problems typically originate due to a complex, multifaceted etiology that includes biological and environmental variables. So making sure that we have a wide lens when we're looking at assessment is going to be really important. So before we get into some of that, I just want to take another kind of initial, this somewhat disclaimer slide. If you're practicing in this particular area, it's really important. I know we have a parent in the audience, at least one, although many, I'm sure, but one that is here hopefully getting information for their own child maybe, that it's important for parents and clinicians who are looking to treat these particular problems to really think about some of the underlying medical issues that might be present before we move into exposure with new foods or interventions designed to increase acceptance and consumption. And so some of those are listed here. This is not a full list of them, but these are definitely things that when you think about are medical issues that essentially make the act of eating and digesting problematic or painful or not so great. So any of you that have ever had experiences with some of these things probably note that you didn't want to really eat while these conditions were affecting you, or in relation, for example, food allergies, associating that really kind of traumatic itchiness or swelling or so forth, or maybe even more problematic to a particular linked food, you're probably not wanting to do that again. So gastroesophageal reflux, or moving any of the stomach contents up through the esophagus. Over time, that's painful. You can get sores on the inside of your esophagus that can not be very pleasant. So we would definitely want to make sure that that's not a chronic issue and that that's being treated before we move forward. Constipation and diarrhea, kind of two sides of the same coin in terms of problems. But any of that is going to, again, result in stomach kind of discomfort and difficulties. It's not very pleasant, and that might be associated with particular foods. It might be associated with the act of eating altogether. And so you may get kids who do not eat when those conditions are affecting them. And those conditions might be more prevalent because of the types of selective diets that they already have as well. We talked a little bit about oral motor challenges and difficulties. Here, again, just making sure that we are preventing any issues by assessing safe chewing and swallowing before we move forward. Again, I'll throw a shout out to our OT and SLP friends here in terms of their roles in helping everybody who's involved at the table, sort of speak. Dysphagia, problems with swallowing. Absolutely one of the major dangers of behavior analysts moving forward with any sort of interventions or assessment for feeding problems is really making sure we're partnering with people who have ruled out that swallowing issues are present in that individual. And then finally, food allergies. We're going to be presenting new foods and foods that maybe that child either has not come across in a really long time or if at all. And we may not know whether or not food allergies for those individuals might be present and could be very dangerous if we are making some assumptions there. So let's then move from that kind of disclaimer and talk about some medical issues to really the scope of practice for medical professionals. And of course, this is very truncated versions of these disciplines, but I'm going to try to hopefully highlight how they can be helpful and useful, especially to behavior analysts in the course of assessment and treatment. So, of course, we have ethical guidelines that mandate that we need to rule out medical problems, and feeding issues are one that I think it is probably safe to say that we can always assume that there may be something going on there. And what might be useful is being provided, for example, medical charts, if you can get releases of information. Now, we need to also be competent in how to read medical charts or what types of information we're asking for as behavior analysts. So if we don't know, then we're going to need to partner with that medical professional much more readily to understand what types of information might be impacting the course of treatment that we're selecting. We might also be able to request or assess whether or not this has already been assessed, but those specific medical concerns that I just spoke about, especially on that prior slide. So anything like allergies or reflux, intestinal failure, digestive issues, things like that. The nice thing about the medical professionals is oftentimes they are also gatekeepers to other specialized services in the medical realm. So GI doctors or dietitians who may be on their own teams or within their facilities that also may allow us to get additional information, get a dietitian to tell you exactly what foods might be really impactful in terms of diet.
Yeah, and as Jonathan previously mentioned, an important part of the scope of practice of the medical professional is that they can conduct tests for food allergies. So food allergies is something that we need to keep in mind at the moment of establishing a treatment and defining the foods that we will present in an intervention. We should be aware of food allergies regarding milk, eggs, peanuts, soy, fish, shellfish, wheat, and tree nuts. And also, according to the US Food and Drug Administration, sesame is being added as the 9th major food allergen, and this will be effective by January 1st, 2023. So there could be other type of allergies, but the one we just mentioned, they account for 90% of allergens in children. So it is very important that when conducting an intervention, we make sure to ask about food allergies.
Yeah. And I think that this is important for, again, behavior analysts to understand when we're recommending, for example, caregivers to just bring in new foods or to present new foods and things like that. Even that recommendation, we should be cautious of in terms of, do we know whether or not that individual's family has a history of food allergies? Do we know whether or not that individual has identified food allergies, or is any sort of allergy assessments that have been conducted with them? And when I am personally selecting foods for intervention, I definitely shy away from presenting any of these particular foods, and especially if I'm not within a hospital setting, where if that did go wrong, that individual is going to be well cared for. So I can't even tell you how many times, at least in the United States, approach this a little bit from my own cultural lens, but you can think about your own cultures. How many families say, I want my child to eat a peanut butter and jelly sandwich? And I'm like, well, I'm personally not going to provide your child with peanut butter unless I know that that is not an allergy that your child has. Um, Same thing with eggs and dairy for us. That's those particular foods, a lot of the grains, sesame being a new one that's being added to this list of foods, those are all combined and processed often with other foods, or combined in processed foods in various ways. And so I don't know about any of you all, but I am not also an expert at reading the nutritional labels and ingredients on things. And sometimes those names change. And so if you're not aware of what those common names might be for those ingredients, then that's where a dietitian is going to be really, really useful for your team. And especially even then, if there is an identified food allergy, we might need to be very, very cautious on then selecting, for example, foods that maybe have some of those components in it. All right, let's move to our friends in speech and language and occupational therapy. And so, what I love about these disciplines is when you think about it, they're absolutely experts in motor movement, speech and language, oral motor especially, and can identify problems with chewing. They're able to assess safe swallowing and whether or not there's going to be any problems there with aspiration, which we do not absolutely want. They're able to identify safe textured foods. So they may have recommendations that, yeah, this child can move forward with behavioral intervention. It's behavioral in nature. There's no underlying medical or physiological problems from their standpoint, what they can assess. But they may say, given maybe some of their experience limitations, or maybe they do have physiological problems of some sort, that they recommend sticking with a certain food texture. They're amazing at developing oral motor skills, I think, well beyond some of my behavior analytic friends. So great techniques in how to strengthen oral motor abilities so that hopefully we can advance food textures eventually at some point. Um, and also recommend appropriate seating for that particular child, given their age, developmental status, and so forth, size. And from an occupational standpoint, are they seated safely to even be able to accept a bite in the first place? So something when I go to visit clinics that are implementing feeding protocols, one of the first things that I kind of look for is, do they have appropriate kind of a meal time structure and equipment and resources to be able to do that safely? Of course, makes sense that you don't want a kid flopping all over the place as they're eating, because that food is going kind of everywhere and has the ability maybe to fall down the esophagus before you actually want it to. All right, let's move a little bit into now the scope of practice for behavior analysts. So I think it's not without any surprise. So given all of your experiences as behavior analysts in the audience, we are really good at identifying why behavior occurs. What is the function of food refusal or inappropriate mealtime behavior? That is, why is that individual engaging in this particular problem? We'll talk about prevalence of this when we get to interventions. We can identify caregiver influence. So how is the caregiver-child dynamic within the meal maybe influencing the likelihood of acceptance and consumption or problematic mealtime behavior, throwing foods or swiping foods or spitting them out and things like that. We love baseline as an assessment of itself. So baseline will tell us how prevalent that problem is, to what extent is that problem kind of currently existing within that child's life, that family's life, so that we can then later on, final bullet point, actually evaluate, hopefully, improvement of what current performance looks like. Increasing mealtime structure. So I don't know any of you if you've ever attempted to implement feeding protocols, if you've ever witnessed a family with a child that has a feeding problem or any individual that has a feeding problem, and just asked to see what that looks like for them. It's a pretty chaotic thing to witness. So sometimes just implementing some structures. Typically, I do that from a data perspective. It's really hard sometimes for me when I say just free form, show me what a meal looks like, to know from a when does one bite start and the other end sort of thing. And so to quantify that, sometimes I put in some mealtime structure for the number or size bites that should be presented, how frequently they should be presented, how many at a time should be presented, and so forth, so that I can make sure that I'm able to quantify what I'm seeing in a much easier way. Sometimes just doing that alone helps with the predictability of, from the child's perspective, what that's going to look like. And sometimes that's an intervention in of itself. And then finally, again, evaluating those particular behavioral treatments. So are we actually improving the acceptance and consumption of new foods, if that's our goal? Are we increasing chewing? Are we decreasing inappropriate mealtime behavior? Whatever those goals might be in our initial baseline, how is that then improving, hopefully, as a function of us delivering the interventions that we're attempting to deliver?
Yeah, well, continuing with the scope of practice of behavior analyst, a sequence of steps for an intervention generally involves, first, we will conduct a sorry, Michelle, were you going to say something? I heard the mic. Okay, sorry. Okay. So the sequence of steps for an intervention generally involves to conduct first a multi or interdisciplinary evaluation with some of the previously mentioned professionals. Then, if present, we will treat some medical problems by the corresponding specialist, and we will obtain recommendations on whether behavioral interventions may proceed and how to safely implement them. Then we will perform behavioral evaluation to assess the severity of the feeding problem, to identify environmental variables and maintain it, and also to obtain information about possible treatment options. Then we will establish clear outcomes and propose an intervention linked to the results of the assessment. After this, we would evaluate the effects of treatment on the relevant dependent measures. We will fade the intervention components, and we will increase the likelihood for generalization. And we will also train caregivers to implement treatment. And finally, we will conduct follow-up sessions to ensure maintenance of treatment gains. So as you can see, there are several steps, and we could discuss each one in depth, but because we have limited time today, we are not going to talk about each one of these steps. We are mentioning them just to give you a general overview of the whole complete process.
There's a lot of steps there for sure. And so why I'm so happy to be presenting with Varsovia is she and our colleague Michelle Sutherland, we wrote a chapter where a lot of the information that we're pulling for today and kind of talking about the overarching area of building competency can be found in our book chapter in this particular book. So if we didn't cover something that you were really hoping we did, please check this out. Also, we don't get any royalties from it, so I'm happy to just, say that. We're not plugging this in any kind of selfish way. But you're also welcome to contact us. We're happy to anything in that order list of sequences of assessing to intervention. Happy to follow up with you at some point, but we will cover some areas that we think are kind of important that we want to highlight.
Okay, so let's talk about general assessment and its purposes. There are at least 3 different functions of assessment. The first one is to identify a problem. So baseline observations and naturalistic information may inform us to what extent a problem is a problem, how severe is the problem, how difficult or how disruptive is the problem of family life.
So this is where, when I spoke about baseline, oftentimes this is some of the information that baseline provides us. So, sometimes a family reports to us that, meal times are a big struggle for them. And then when you ask to see it, no problem behavior occurs. So it's not that we don't believe the family, but something else might be going on there that we need to kind of further assess. And it might not be as big of a problem that it was communicated, at least. It might be a different type of problem that was not really understood at your initial meeting with someone.
Okay, and the second function is to identify the best course of treatment or the next steps or decision. So assessment can help us to identify a function-based treatment and guide us on other decisions, such as to identify if we need to focus on some textures, type of food, if the kid likes some food better than others, etc.
So here again, assessment in other disciplines looks very different. But again, it's same kind of general overarching theme is providing you with information to guide your next steps. And so, of course, when we get to functional analyses, those of us that are familiar with functional analyses, of course, it predicts very specific treatments that are going to be effective, and that's why it's a great assessment tool. We're going to talk about other types of assessments that might help us predict courses of treatment.
And the third function of assessment is that it allows for evaluation of the effectiveness of our intervention. So it allows us to compare pre and post intervention data and whether or not we are being effective in treating a problem. It is important to mention that all assessments should be performed to gather information. The information that should be guiding of course of treatment. This means that we should make data-based decisions. Sometimes we need to be competent in identifying whether the information that we might need is within our scope of practice. If not, we need to refer to others to conduct assessment on our behalf, and sometimes before we might be able to continue with the behavioral approach. So focusing on behavior analytic approaches to assessment, many people, I think, in the audience will be familiar with this. We have these 3 general categories: indirect assessment, direct or descriptive assessment, and functional analysis. And we will discuss each one briefly. So with indirect assessment, the evaluation is based on a proxy report of the child's behavior via clinical interviews, feeding inventories, interviews with caregivers, food diaries and logs, or discussion with the children themselves. As we previously mentioned, our assessment should incorporate information from a multidisciplinary model that could incorporate speech and language pathologists, pediatrician, dietitian, occupational therapy, gastrointestinal doctor, and this in order to make sure that it's safe to proceed forward. And it's a good idea that your treatment is person-centered. So we should incorporate information regarding the history of the presenting problems, if there are food restrictions, family diet, and also have a general cultural understanding about the family mealtime, about the general environment, how they eat, who feeds, what they eat.
Yeah, Margaret asked if there's any specific questionnaires or food inventories that we can recommend. Generally, Margaret, I have a specific one that I've tailored for myself just based off the areas that I'm in and the types of clients that I'm typically seeing. And so here really, I would like to kind of widen your lens a little bit beyond anything that's specific per se. But there are some go-to, like Varsovia kind of hinted on, Any questionnaires that get at history and food allergies and current diet are, I think, really important. You're going to read about probably different types of food inventories, especially when you look at group design literature. For example, the BAMBI, BAMBI, is a commonly used kind of feeding questionnaire within a research purpose. But back to the function of assessment, we really need to be competent in first identifying, I think, not what assessment we want to use first. It's that what types of information do I need, and then use the assessment that makes sense to give us the information that we need in that sense. So, for example, I once had a child who went through my initial intakes. I have all these questionnaires that ask about current medical problems and things like that. I think it's pretty thorough. And then we got to the first day of presenting kind of new foods and finding a baseline for whether or not they ate those particular foods or not. And all I saw was the child rubbing their jaws and refusing to eat and things like that. So topographically, it was a little bit different than what I had experienced prior to that point. And I look back at I do a food log as well. So caregivers do about 3 days of what their meals look like at home. And I was looking through the types of foods that they were eating. It was nothing but junk food and high sugar content. And I told myself, this kid has this kid has like teeth problems. And so of course, try to get them to open their mouth and look a little bit. I'm not a dentist. I can't assess that. So I don't know whether or not this is actually painful now to chew and swallow, and whether or not you have some sort of cavity forming or, long history of that's now impacting that particular client. So I had to change my whole assessment framework, and I had to say, at least for that particular client, right now, I am not doing anything. And I'm going to assume probably that this is the case given the variables that are in play. And I have to wait for a dentist to see this kid and maybe even take care of that before I even proceed forward with anything different. So I needed a lot of other individuals to help me there. But I use that example just to kind of highlight again. There are some that are good. I think there are some that kind of catch a lot of things. But if you're thinking to run the gambit as well, I'm going to just do all of these things. Yeah, you'll check the check boxes for being really safe, but you also prolong treatment as well. So it might not be the most efficient thing to do either. So there's a little bit of a balance there. Thanks, Sarah. Yeah, I prior to that point had not even thought about dentists being involved in my work, but now it's something that I am constantly paying attention to. That was me very young, early, and not as competent as I am now. And to highlight, we all grow, right? I was pretty good at that point. I think I'm better now, sort of thing. And so we can move forward, learning from all of these experiences, and now help other people hopefully learn them. So again, I'd be happy, Margaret, if you want to, I'll post my email at the very end. And if you want to contact me, I'd be happy to provide you at least with some of my questions that I ask and things like that. So very, very good question. Yeah.
Okay, so with the direct methods, these refer to the observation of the child's and feeder behavior immediately prior to, during, and immediately following meal times, as well as observation of environmental conditions that could be mediating the observed behavior. So direct assessment methods will also be implemented in an effort to evaluate patterns of food consumption and refusal. For example, if a child is food selected by type or texture, to systematically observe and describe social and physical conditions that may maintain food refusal, to experimentally determine the experimental or environmental conditions that maintain food refusal behavior, and also to obtain baseline measures of performance.
So there could be, again, a number of reasons why you're running different types of assessments. And so we highlighted some here. We're very used, I think, as behavior analysts, running preference assessments. So in those various formats. And oftentimes with individuals with feeding problems, You'll even come across this in the literature as well, where we will run a lengthy paired stimulus preference assessment. That's the graph at the very bottom there that you see. I'll explain in just a second. Typically, the purpose of that particular assessment is to identify preferred stimuli to be used as potential reinforcers in a reward or reinforcement-based paradigm. And with kids with feeding problems, it's hard to identify sometimes, especially the most highly selective or those that don't eat any foods at all, edible reinforcers, because those aren't functioning as reinforcers for that population. So for example, this particular graph on the bottom, the black bars are the pre-treatment paired stimulus preference assessment. So they were only eating really two foods at that point in time, the Pediatric and cookie. The yogurt was accepted, I think, once. So it was nice to know that they could do that, but it was not a persistent selection. So everything else was not selected in terms of acceptance and consumption there. Now, the purpose of running that for us was not to identify preferred stimuli. We can identify those in different ways. A single stimulus for this population in terms of identifying will they or will they not consume a food is a really quick way to assess that, if that's the information you're trying to get. For feeding problems, typically any other type of preference assessment is not really being used in the same way as other areas. Now, it can be if you're using all preferred stimuli or at least reportedly preferred stimuli in that assessment, and then that is the reasons why you're using that particular assessment. Oftentimes when you see data like this, it's from that third reason why we use assessment, the evaluation piece. So what we did here is we ran the same assessment prior to intervention and post-intervention. So those gray bars are now the increases relative to those black bars following treatment. And so then essentially giving us some information of, was this a good course of treatment for this individual? Did it actually impact the behavior we wanted to impact, that being preferences, selecting and consuming a variety of foods? And so with these data, we would say yes. For those of you who are not familiar with preference assessments, the paired stimulus preference assessment is a choice paradigm. So you present two different foods or stimuli to an individual and have them select one over the other. And so you should see a perfect diagonal line from the right hand or left-hand side to the right-hand side. You don't necessarily really see that. So that rice, pasta, cauliflower, and broccoli are not selected at all, which does tell us that those are probably still non-preferred foods. But in a paired stimulus preference assessment, if you even select something every single time, it is possible that you will have one item that is never selected because you're choosing something else over it at all possible opportunities. So it doesn't mean that that would necessarily be a non-preferred food or stimulus per se. We'd have to probably assess that individually. It just means that everything else that was chosen instead of it is just more preferred in that sense. So I have some articles, Varsovia and I have some articles that we've done some of this work with. And so I think it's important to just recognize the why element of why this assessment and what information are we gleaning from this. Behavior analysts in the audience, there's not always one rhyme or reason to things. And sometimes when you're reading articles, editorial boards make us cut all of that juicy information out of why it is that we are doing what we're doing sometimes. So it may not always be readily apparent and kind of there in black and white words for you. Of course, we try to hopefully argue back and keep those words in there as much as possible, but sometimes they do get edited out. And so it might be really important to continue to have these conversations and engagement, reach out to those authors and ask them, why did you do X, Y, and Z? They're hopefully more than happy to answer some of those questions for you. All right, let's move into functional analyses. So in functional analysis, this is the manipulation of antecedent conditions, and we'll talk about antecedent interventions in just a second, as well as consequent events to problem behavior, inappropriate mealtime behavior. And we manipulate those to determine whether or not those variables are impacting the child's behavior in some way, the problem behavior or the likelihood of acceptance and consumption. IMB here is inappropriate mealtime behavior. And it's not without surprise, those behavior analysts in the audience, that this accurately predicts effective function-based treatments. It tells us exactly kind of what we should be doing next. I'm going to highlight here that the likely maintaining variable in food refusal or inappropriate mealtime behavior is negative reinforcement. That is, that kids engage in problem behavior in the mealtime context because it effectively removes that food that they don't want to eat, or that they don't have to eat it, or that there's a break following the request or instruction to try new food of some sort. And it's that relationship that tends to promote future likelihood of increased inappropriate mealtime behavior. That being said, if escaping the mealtime context in some way, shape, or form is exacerbating problem behavior, and resulting in that kid continuing to refuse to eat the things that are going to eventually make them a healthier person, then those are the variables that we want to target for the escape variables, or what we want to target. Why is it that this is such an aversive kind of situation for this individual? And it may be related to a prior history of medical problems, right? What we talked about. And even when those problems go away and it's no longer painful to eat, let's say, that history still remains, and that learned history of engaging in problem behavior are still there. And so we then have to target that. So let's move into, now that we've talked a little bit about assessment, again, that's not a full scope of all the possible assessments out there. And I think our literature in feeding is really growing in that area in terms of all the types of different types of structured assessments that we could run. And again, keep an eye out for why was it set up that way? What information does that design, that particular procedure of assessment tell us in terms of moving forward with telling us how bad this problem really is, or what the nature of the problem is, and what types of treatments might be effective, or giving us information about how effective our treatment actually was. So in those particular domains is what you'll probably find the rationale for those various different types of assessments. So let's move a little bit into treatment realms. And of course, those hopefully should be based on some form of assessment prior to implementation. But for those of you that are not familiar with these terms, antecedent-based interventions are treatments that are typically implemented before food is even presented or accepted. And so their aim really is to decrease the motivation to engage in inappropriate mealtime behavior, or facilitate acceptance and consumption in some way. It makes it easier to do those appropriate behaviors that we're looking to see. Consequence-based treatments are treatments that are implemented following the presentation of food, and those are interventions that are incorporated, that incorporate procedures following the occurrence of inappropriate mealtime behavior. So they're consequating inappropriate mealtime behavior in some way, or they're consequences for acceptance and consumption and those appropriate behaviors that we want to see. And the decision for using one approach over another, or a combination of treatment components, both antecedent and consequence-based interventions, are going to be impacted and influenced by a lot of different variables, and likely not ones that we can kind of share and predict, I think, in a very specific way here, but just something for you all to think about is the severity of the problem, recommendations from other professionals, the results of your assessment procedures like functional analyses, the safety and risks for implementation of those procedures, which impacts, again, facility resources, or the competency of staff who are implementing those procedures, or the caregiver and child's consent for those procedures as well. So those are just some variables that we were thinking about that might play a role in the selection of various different techniques and what you might choose. So we're not going to go into, again, a great detail of all of these necessary procedures, but we'll describe them. We'll go through some of those options. And we did want to provide you, at least for some of you on the more basic beginner and novice side of things, that these are some things that you can look up and continue to research on your own as well. So the first one we'll talk about is antecedent-based interventions. So blending refers to mixing two foods together, and typically that's a pureed texture where then you are then probably incorporating some form of fading technique. So you're usually starting with a high proportion of high preferred food, that is a food that is readily consumed, and inserting a small proportion of non-preferred food or the food that is not currently being consumed. And then over time, as you get successful acceptance and consumption of that blended mixture, you're then going to fade the proportion. You're going to increase the amount of non-preferred food in that mixture to the high preferred food, and you're going to make that one smaller. So it's just that gradual change. For the behavior analysts, we recognize that as fading from or transfer of stimulus control from one context to the other. So fading can happen across a variety of different food characteristics as well. So not just in blending, but it could be changes in texture, proportion like blending, or even the size of solid food as well. So you might start with a really small size. We'll talk about bite-size fading in just a moment here. It could even be proximity as well. So I know that many, for example, SLPs and OTs will also recommend maybe an initial start where the exposure phase is just a fading of where that food is relative to that individual. Moving on to simultaneous pairing. So this might be also termed simultaneous presentation in the literature. And this is very similar to mixing, but now we're just talking about solid food. So it's placing a preferred food and a non-preferred food together on the same spoon oftentimes, or the same bite, and presenting them at the same time. And so the example here is using something like, if you're not eating apples, well, you might put some honey or some peanut butter on it that is preferred, that makes the apple a little bit more delicious and more likely to be consumed. I know that in many cultures, vegetables are typically a non-preferred food, or they're not readily consumed as much as other foods. And in order to eat them, typically you slather them in things like cheese and ranch and blue cheese or other types of condiments, and you get an increase in consumption. So same concept here is that you would do the same thing with combining a preferred food and a non-preferred food together. It increases the likelihood of eating that non-preferred food. So there's a lot of different types of examples, but you would be using an assessment that then tells you what foods are preferred and non-preferred, and then hopefully moving forward with an evaluation of whether or not that particular arrangement, putting them together, is a useful arrangement. All right, providing choices. So I mentioned this here, that there's some emerging literature on presenting choices and presenting choices between non-preferred foods at increasing the likelihood that you might get consumption of the one that is chosen. This may also provide us some information about which non-preferred food is less aversive than the others. So I always, when I present on feeding problems, talk about, we all have idiosyncratic or individualized preferences. And if I were to say, I'm going to choose between these two foods that you don't like to eat, which one we're going to move forward with, and you're going to, try and hopefully enjoy eventually, you might have a say in which one of those foods gets selected by me. So this gives kids or the individuals in our treatment protocols a little autonomy over selecting which foods that they want to kind of go into treatment and things like that. I also like to use this as a kind of acknowledging back to us when we're doing those initial selections for a treatment protocol and identifying what foods go into treatment or are selected for a course of treatment. Why those foods? So maybe a dietitian is going to be useful in selecting them because of a nutritional standpoint, but oftentimes those individual food items could be replaced by a number of different other foods that will have the same nutritional benefit. So if we start to see that a kid really just does not like a particular food that was selected, can we rotate that out with something that is comparable in terms of nutritional status, or that particular category of food that is really missing in their diet? All right, so let's look at decreasing bite size and quantity. So this is, again, a fading protocol that you might start with as well. So on the left-hand side here, we have the smaller chopped bites relative to on the right-hand side of that picture, you see more larger size bites. And when you're initially starting to work on foods that a kid or individual is refusing, it might be worthwhile to one, standardize what size you're looking at, so that if you do need to then say, okay, well, maybe we should evaluate whether decreased bites are a good idea. You could do that. Now, you could also look at over time then increasing the bite size or the number of bites that are presented during a meal. And just by the sheer nature of decreasing those expectations, hopefully there's also a reinforcement-based component, which we'll talk about in just a second, that kind of takes over, and the individual then hopefully can then contact reinforcement contingencies and increase the number of bites from there. Oftentimes I talk with other allied professionals of, sometimes our end goals are just way too lofty. And why don't we kind of take that back and make this a little bit easier for the individual, get some success, and then encourage increases from there. And sometimes that's a really useful conversation to have. Sometimes parents, especially in the United States, I often see the biggest portion sizes I've ever seen in the entire world. And so sometimes it's nice to say, whoa, let's start back at, a bite for bite kind of relationship here. High probability instructional sequences. So you might see this as high P sequences, high probability instructional sequences. You might see this as building momentum. There's a lot of different kind of terminology that's used here, but essentially what this looks like is you're delivering several instructions that the individual has a high likelihood of following. So those would be those high probability instructions. And you do that before delivering a low probability instruction or that target demand instruction. So typically in feeding, that is the instruction to consume the food would be the low probability instruction. And there's a wealth of literature here in terms of different variations on this, how many instructions are delivered, what types of instructions, whether those instructions are feeding related or not feeding related, and so forth. And there's been some split kind of results in terms of efficacy here. So I do mention it as one that has been shown to show some success in our literature. And it is a technique that can be used and is often also used by our allied professionals as well. And they might call it different things, or they might have other overlaid components within kind of their different types of treatments that they use too. But it's one that I think is worthwhile in talking about. All right, and then lastly is non-contingent reinforcement. So this would be just providing access to preferred stimuli or reinforcers, whether those be the functional reinforcer or a non-functional reinforcer on a time-based schedule. So that might be continuously throughout the meal. It might be every 10 seconds or so forth. But essentially this is where, they might be watching, for example, a preferred show during meal times. Continuously, you might sing to a kid, they might have access to a toy, or you might be providing non-contingent breaks throughout a meal as well. So that could look in a variety of different ways as well. You will see that in the literature when you do a review, that whatever that item is, whatever that stimulus is, varies as a function of whatever that clinician kind of decides. So I want to talk about how antecedent-based treatments can be highly effective for mild cases of feeding problems, and that is typically kids who have kind of mild forms of food selectivity and don't really have any concurrent medical complications. Let's move to consequence-based treatments. So again, these are treatments that occur or manipulate things following problem behavior or acceptance and consumption. So differential reinforcement is just a procedure that is delivering preferred items, the reinforcer. So that could be a preferred food, a preferred toy, social interaction, number of different things that have been shown to be preferred by that individual and function as a reinforcer, contingent on food acceptance and consumption. So you could think about this almost as a kind of dessert relationship. So you eat the non-preferred food and you get access to a preferred food, let's say. That dessert could look a different way. But and typically what we are doing for here, we will get there, Michelle. Thank you. About my experiences. Hopefully we'll have some time for that. The relationship we usually start with is a bite for bite relationship. So usually it's eating one bite of non-preferred food and you get a bite of preferred food or access to a preferred item. And again, that's not the end goal for us. That's a very contrived looking meal, but we want to get to a much more naturalistic type of meal, and we will eventually. But to start with something easy, very predictable, it tends to be a really highly efficacious kind of format. Kind of to tie Michelle's question in here, I've had a lot of caregivers that do push back on that. They're like, well, why do I have to do that, like a one bite for one bite? And I think knowing that that is going to result not only in immediate success, but that is the roadmap to getting to more long-term success is something that we really need to be clear at explaining to caregivers, especially that we recognize that we're not meeting what your end goal is right now, but it's going to take us a little bit of time to get there, but we will, and just be patient a little bit. All right, let's move on to escape extinction. So escape extinction typically consists of presenting the non-preferred food, whatever that food is that is not being consumed, without removing it contingent on inappropriate mealtime behavior or problem behavior. And it should be noted that escape extinction is typically the mechanism behind why different procedures from a topographical stance, that is, that these procedures look very different sometimes, why they're effective. So different procedures might be termed differently, but typically are explained to be effective because the mechanism behind behavior change is in place, that is, escape extinction is in place. And so all of these procedures, inappropriate mealtime behavior, no longer results in access to removing the requirements to consume the non-preferred food. So you might read about non-removal of the spoon, you might read about physical guidance or bite representation, especially for expelling bites, and bite redeposit, especially for individuals who are engaging in packing. And so it should be noted here that the implementation of those particular techniques does require some training for timing and technique, making sure that individuals are safe, when to implement this, and so forth. And it's important for clinicians. I know there's many out there that don't have experiences and competence doing this procedure, that that they still recognize that even if you're going to move forward with antecedent and reinforcement-based procedures, that you may need to implement this at some point. And it may not be you, but you should have some, hopefully, referrals, what to do if those techniques prior to that don't work. Are you going to refer to somebody else and things like that? But we should also recognize that it is currently the most empirically validated treatment for especially severe food refusal and this population that I'm kind of talking about. So I don't think we need to shy away from it and rule it out as something that we shouldn't be doing. It is highly efficacious, but there are definitely things that we need to think about in terms of competency and ability to implement this procedure. Okay. Yeah, so this is used for a treatment for acceptance and consumption and inappropriate mealtime behavior. All right. So I want to highlight again that everything we kind of talked about is a really highly structured, not our end goals necessarily. So those types of interventions are interventions because they're changing what the current kind of mode of meals look like. And our goal at the end of things is to fade all of those components I just talked about to end up with typical meals, whatever that might look like in terms of portion and engagement and location and so forth. That kids are eating across environments, not just in our clinic or at the table that we did this with. That we have long-term follow-up and are guiding parents to make new decisions on their own. that we've impacted changes in preferences, that kids fundamentally like the foods that we've worked on, and that they're motivated to continue to eat them under less structured contexts. That is generalization, that we've impacted their likelihood of eating new foods, and that we've done some caregiver training and caregivers feel comfortable moving forward.
Okay, well, now we are entering to the last part of our talk, and we will focus now on ethical considerations and competency. So as a general rule, there are several questions that you could ask yourself when implementing a feeding treatment. For example, you could ask, would you implement this approach for your child, a member of your family, your friend, yourself? Would you be comfortable with someone, for example, a caregiver, another professional, witnessing your approach? Would you be comfortable talking to others about your approach, writing a news article on your approach, posting a video online? So how you answer to those questions could indicate how confident you are implementing the right treatment in a correct manner. If your answer is negative, you may need to think about the scope of your competence or contextual factors that may be influencing the appropriateness of your treatment selections. So now about the scope of competence, Brodhead and colleagues in 2018 published a paper named A Call for Discussion about Scope of Competence in Behavior Analysis, and they provided some definitions about the scope of practice and scope of competence that are really helpful to differentiate among them. The term scope of practice is used to refer to the activities in which members of a profession are authorized to engage by virtue of holding a credential or license, and is determined by external oversight organizations, whereas the term scope of competence is used to refer to the range of professional activities of the individual practitioner that are performed at a level that is deemed proficient and is determined by the individual practitioner. Something that is important to highlight is that while the responsibility to establish the scope of practice is stated by behavior analytic organizations, the responsibility for determining the scope of competence falls to the individual professional.
That sounds scary a little bit, right? So in terms of scope of practice, like Varsovia is saying, we have a lot of agencies that, like the BACB or ABAI or other types of accrediting organizations and so forth, that really regulate the scope of practice. That is where behavior analysts can work and what they can do. Whereas within that scope of practice, the scope of competency, whether or not we do those things, is really determined by us. And so that's, I think, really where Varsovia and I love having these conversations with individuals, because we are confronted with these particular problems so readily, and yet many behavior analysts don't see this area as an area of their scope of competence. And so I love having you all here today. Thanks for moving forward with building your scope.
So what are the variables that may influence practicing outside one's scope? Brodhead also mentioned some of these variables. In the first place, he mentioned that practitioners may be motivated to practice outside of their scope of competence when demand for services is so great that individuals that desperately need treatment would otherwise receive not service or experience a long delay to accessing those services. Also, a professional may accept a case because they feel more qualified to serve that consumer than other available professionals, for example, from other disciplines, even if they do not feel optimally qualified. Also, of course, the financial resources for serving consumers may compete with the ones associated with transferring a case to a more qualified provider. In addition, there is significant response effort and cost for obtaining supervision or consultation to be able to adequately serve that consumer. And another variable is that many behavior analysts may not have been explicitly taught how to identify the scope of competence, and therefore they may have difficulty recognizing situations that are outside of the scope of competence. And a final one is that a behavior analyst may confuse the idea of the universal applicability of the principles of behavior with the idea of universal capacity to apply those principles in a competent manner. So just because we should do something doesn't mean that we can actually do something.
Yeah, I love this article because I think Broadhead gets at all these contextual variables that might be impacting our behavior of whether or not we even accept a client or a client with a presenting problem, like a feeding problem, in the first place. So many of you, again, who are confronted with these types of issues, I think are because demand for services are really high. These kids are already in your clinics. You're already being confronted because you're working with on other problems that they may have that they're seeking services for. Families are requesting it. And we don't have a lot of community, I think, resources, especially for behavior analysts in terms of how to move forward with some of these things. So we'll give you hopefully some resources for hopefully combating some of these problems. But while I think of it now, just get involved with some of the special interest groups, ABAI's feeding disorders special interest group. I know there are some state level ones. Tex-ABA, I think, is forming a really, really good one. So if you are in the Texas area, or if you're outside of Texas, join, become a member, and start continuing to build your own competency.
And when related to this, there are several risks of practicing outside of one's scope of competence. And this can be categorized into risks to the client, yourself, the agency, and of course, the field. So regarding risk to the client, the assessment and intervention effort may result in poor outcomes and may increase the risk of harm to consumers. Also, there may be a deleterious effect on the practitioner. For example, the confidence could be shaken, and the field of behavioral analysis also. For example, the field could be perceived as ineffective. Also, practicing outside of one's scope of competence puts the behavior analyst at individual risk for disciplinary action from relevant regulatory bodies. And also, it is possible that behavior analysts practicing outside of their scope of competence may be also engaging in other unethical behavior, which increases the probability of consumer loss on funding, litigation, and general damage to the field.
So I like to think about some of these risks for practicing outside of our areas of either scope of practice or competency. Sarah, thank you. We're going to go over that in just a second. The things that I keep thinking about in our field are things like our insurance fraud, at least in the United States, or people who are behaving unethically. And that has a reflection as a whole on not only our profession, but allied professionals as well should probably be concerned about, that as well. So speech and language pathologists or occupational therapists should be concerned about behavior analysts also doing things inaccurately or incorrectly with respect to feeding problems, because it may also impact them too, in terms of continuing to forge relationships with people who do know what they're doing, in terms of effective treatment for the clients that we all serve, which is number one priority. It's what we all want at the end of the day, is improvement in eating. And if we can't be as effective doing that without certain key people at the table, that would be problematic. And consumers at large might just start seeing that this is not an area that can be improved if people are just ultimately ineffective at doing it when they're reaching out for services. So just some things to be thinking about as you move forward with really anything. And we're talking about scope of practice and competence here, but you could replace feeding problem with anything really, and you would still have a nice discussion about that particular area as well. So let's move a little bit to the assessing and building of competency for ourselves in different disciplines. Again, talking a lot about behavior analysts, that's the largest portion here, but don't feel left out if you're not a behavior analyst, and we'll continue to say what you can do or how you can learn more about this particular area, or who might be providing treatments for the people that you love or who are in your lives. So as just the chat said, thanks Sarah Mead for talking about this. Broadhead has a wonderful table here, a series of questions that was published to assess one's confidence in implementing either certain procedures or techniques or with certain populations and so forth. And he defined confidence as one's estimation of the likelihood of effectiveness based on your past experiences, knowledge of the literature, and availability of resources, which makes sense that you are going to probably be more effective if you have good prior experiences, good knowledge of the literature, and good availability of resources to engage in the practices that you are engaging in. So here are some of the questions that he asked are, given the current behavioral problem specific to this talk, let's say we have feeding disorders, or even more specific, we have food selectivity, or even more specific, we have a child who does not eat, let's say, any vegetables. So food selectivity, what is my level of competence in procedures and strategies to treat food selectivity? With that population, let's say maybe it's a child with autism, within, let's say, clinic-based early intervention setting or so forth. And you can change, again, what I love about this article is you can change the behavioral problem, you can change the parameters, you can be as specific as you want to. Instead of talking globally about feeding problems, you can start looking at various different areas to assess your own competence. So for example, Varsovia and I can take this same exact questionnaire and apply it to ourselves. So I can be open and honest. One of my particular areas of low competence is in the area of chewing. I do not implement chewing protocols very much. And so anytime I see, I'm good at assessing whether or not there's probably an issue there, but treating it is a whole different story. And have I done it? Yes. And there's been different things that I'm building competency in. But when somebody comes to my clinic and says, hey, I want to work on chewing, typically I have to then find related resources, especially speech and language, who can help me out with collaborating on that particular client. So I would rate myself lower on that than I would, let's say, reinforcement-based or escape extinction-based protocols for the treatment of food selectivity. I love this checklist also for looking at ongoing competency as well. So, you should be using your current and past experiences as they go to say, hey, am I on the right track? Am I still competent in this area? Do I need to stop? Do I need to do something different? Do I need to ask other individuals and so forth? All right, let's look at some viable means. So a lot of this is coming from the literature on building competency. So that Broadhead article being a major one. He's one of my go-to people for anything in terms of ethics and competency. So how do we develop competence? And all of these are going to be viable means to establish, maintain, and refine your skill sets in ways that increases the likelihood of competent performance or effective clinical intervention. And so I should note here that although we're going to start with academic coursework, so coursework does not guarantee competency in a specific area, but it can provide a foundation of information for which people can then build to accessing experiential training. And so people here might enroll into a class, they might audit a course. If you're a student or not a student, you can do some of these things. So you can request a syllabus or reading list, or maybe in-class activities from a university professor. You could attend one of their laboratory meetings, or it could be a clinical laboratory meeting of some sort. You could advocate for a special topics course, especially if you're a student. Go to your department heads and say, I want to learn more about this. Can we have a special topics course in this to be added either to the curriculum or as an elective? You can also ask faculty to incorporate feeding-related literature or examples to the current coursework that is being taught as well. So those of you who are not students, you can still engage in these activities as well, maybe just not necessarily as a student. So it might be that you ask a faculty member to sit in on the day that they lecture for a feeding topic of some sort. You can also independently review the literature on your own. So I would really encourage people to set goals around reading certain studies in a specialty area. And again, being very kind of specific. So maybe it's not just feeding disorders, but maybe you're looking at a particular intervention like sequential presentation or simultaneous presentation or what have you. You could also establish a book club. And what I love about book club or reading clubs or journal clubs is they establish social contingencies around whether or not you are reading. But what I love about that too is that then you get to discuss and you get to have questions about, again, beyond the black and white letters in the pages that you're reading. So the why are people doing these things? And you are going to get hopefully more experiential kind of discussion around other people who are present at that meeting. Practical experiences. So, of course, obtaining supervision in feeding, asking those around you if they've had training. I see the chat. There's lots of people who have done things and are competent in different ways, utilizing other people's areas of competency to grow your own. You might get a new job under someone who can provide you those skills, or you might request consultation so that you can build those skills as well. And then finally, professional development. So workshops like this, trainings and conferences to provide you with, again, that informational side of things. But again, um, we really should be looking at a number of different things as behavior analysts, especially. So behavior analysts are obligated by the conventions of the academic discipline and guidelines of our professional conduct to stay in close contact with scholarly literature. What that basically means is our competency is never done. It's continuing to develop and grow as our science and clinical techniques change. So I couldn't talk about building competency. So those of you without talking about maintaining competency as well. So very similar kind of strategies here. Those of you that have already built competency in area, don't lose your competency, keep it. And some of those things that you'll need to be doing are subscribing to and reading journal articles that come out with kind of the latest research and clinical technique. And even if you're not paying for subscriptions, oftentimes you can get notifications and updates when certain keywords are being published from certain journals or things like that. And you can stay in contact in academic related platforms like ResearchGate or Google Scholar and things like that to stay up to date on the most current literature, interventions, and techniques that are going to influence you in your clinical practice. Of course, attending conferences. I love workshops and especially workshops that have kind of a behavioral skills training-esque model where they can provide you with ways in which you can practice a technique or provide you with feedback on a technique. And then absolutely, especially in feeding, collaborating within and across disciplines is vital. I don't think, given all the initial stuff that we just talked about, that we couldn't say, if you're doing this all by yourself, not that you're going to be doing it wrong, but you might not be doing it in the most efficient ways, the most effective ways, and you're not probably staying into up-to-date techniques on what those other professional providers are doing. So if you're an allied professional, they're also growing in technique in different ways from what their sciences are telling them to do as well. Ooh, there we go. Okay, I don't know what happened there. Attending a training and workshop like this, however, may be insufficient to expand your scope of competence, at least without additional supervision from qualified professionals in that area. And so I mentioned this, again, coming from that direct quote from that Broadhead article. I mention this because he goes on to say that supervision may be one of the most important elements to our practice and building competency because field-based experiences provide exposure to a number of different types of contingencies at the interpersonal, cultural, and legal level. So even here, like we're talking with people who span the globe, which I think is amazing. But things that are relevant to me and my practice in the United States are vastly different than Varsovia and her practice in Mexico, and therefore also different than the many countries that you all are signing in from. And so I think ongoing supervision will provide you with access to what that looks like within the countries that you reside, within the areas, the geographic regions that you reside, and all the different types of factors that may be influencing you. For example, various employment settings might have commonly used techniques and interventions. Their scope might be different at those facilities than other facilities, and they may have a variety of different types of things at those three levels that might influence how it is that they behave with respects to their clinical practice. All right, I said I would put up our email, so now is your chance to jot those down as well. I just want to close up by saying thank you so much, especially to Dr. Michelle Kelly for inviting us here today. We do have some time, so hopefully we can address some of those questions. I saw the chat going a little crazy with all of your prior experiences and the types of techniques you're familiar with. I'd love to have some more questions to answer, but thank you again so much, and thank you, Varsovia.
And thank you, Jonathan, and thank you again for inviting us. And we can also have a reference list that we can send you. So if you send us an email, we can send you back that reference list. The list is not a complete list of scholarly work, but it will definitely get you started on readings that are foundational to building competency in pediatric feeding disorder. So please do that.
Sarah, you said there was a question about references for interventions with individuals with ASD. The ones that we talked about today, many of them have been used with individuals with ASD. It's one of the primary populations that behavior analysts work with. So many of the feeding disorders literature includes that population. There have been some specific reviews on literature used with that population specific to feeding disorders. But I would also argue anything that we described today has probably been validated with that population. And then to echo Varsovia's statement, we do have a ongoing kind of reference list. The one that we put together is specific to some of the things that we talked about here today. So if you do email either Varsovia or I, we're happy to pass that along, and it definitely would get you started on kind of where to go from there. Okay, Christina. Can I provide a good upcoming workshop using BST? I don't know any that are specific in feeding yet, but I would challenge you to, when you go to a conference and you see any workshops that are available to you specific in feeding, it might be a good idea to reach out to the person who's conducting it ahead of time to see, is it just going to be an informational type of workshop, or is this going to be something that is more of a hands-on? What types of skills are being trained in that? Because it could look vastly different depending on who's teaching it and what their aims are. So I would do that. Hopefully at some point, maybe Varsovia and I will do some of that work ourselves in the future. We have partnered a little bit with the special interest group for Text ABA. They're still in their somewhat initial, I think, stages of kind of continuing their work and development. So we're hoping that that will lead to some more opportunities to have these discussions about ongoing competency and lifting our field up in ways. So how is it that we can recognize where we are as a field, building competency in feeding, and moving forward with allowing you all to have those various skills.
There's a second question that for the feeding SIG, do we just email Dr. Piazza to join? And when does the SIG meet at ABA next year? So if you go to that link that Michelle sent you, I think that the information about who you can send an email to join to that group is posted on that link. And usually there is like 1 or 2 days where the SIG meet for every conference. So you can go to the program once it's online and you can check the specific date for that meetings.
All right. Are there references in which eating refusal is due to environmental changes in ASD? I'm not quite sure what you mean by environmental changes in ASD. So I think we can talk about there might be, I don't know if you mean, for example, like moving or things like that. But many children, especially with an ASD diagnosis, do engage in rigid and repetitive behavior. They tend to like very structured environments as a whole. I'm speaking kind of globally here, and that may influence an individual's willingness to eat under certain contexts and so forth. I've definitely had kids who, there's a lot of kind of chaos in that sense happening, and it does impact whether or not they are engaging in the patterns that we want them to engage in, the appropriate eating patterns that we want them to engage in. And so that's possible. That may also pop up when we are treating as well. So like I said, we talked about structuring the environment in a very specific way, and one that is not our end goals, at least at the initial stages. And so those disruptions may influence the likelihood of generalization, let's say. So are they, if let's say we are teaching them to eat in a specific chair at home, and that's kind of what we've geared up to do because we think that it's going to be really good at establishing those initial stages, and then something happens where now we can't do it in that context, that might influence our course of treatment. Let's see. Thanks for all these questions. Okay, we have a little bit of a case.
Yeah. Here, Dr. Jonathan from Margaret, how important is it to target having unprepared food on the child's plate versus just getting her to eat it? And at what point should I target having the child eat independently if she eats less than 30 food items?
Yeah, I think for this, I don't want to shy away from, personal kind of examples or, kind of assessment and treatment for people who are in your lives. I have to be cautious about recommending anything, of course, because I have limited information to make those recommendations. So caveat there. I would say one, reach out to all the professionals I just mentioned and get some other professionals around you that can get some eyes on what's going on and provide you with more specific types of courses of treatment. It also, in large part, I would say, would depend on your goals. Is your goal for them to tolerate the piece of food? Or is your goal for them to, I know it's probably eventually to eat that food too, but so I can't say it's a bad thing necessarily. Oftentimes my approach is to an exposure protocol coincides with the literature, which suggests that exposure in terms of taste is a vital and crucial component to increasing preferences and increasing acceptance and consumption. So I think the faster you can get to some sort of taste exposure rather than just visual exposure might be a good thing in terms of the goal to eating it. Now, that's not to say that presenting it just visually and having them somewhat tolerate from a decreased inappropriate mealtime behavior perspective is a bad thing necessarily. It kind of just depends, but yeah. Hopefully that helps.
Perfect. Thank you so much, Dr. Jonathan and Dr. Varsovia. It's 6:58, so we might be able to take one more if you're very quick to type it in the chat right now. But in the meantime, there's one from Paolo. Is it possible to use the treatment protocol for beverages?
Yes. So Varsovia, I don't know if you want to tackle that one.
Yeah, well, you already answered that. Yes, it is possible to use treatment protocol to beverages. And I have seen some cases where kids, for example, they don't like to drink water, for example. And for example, they only drink like juice or soda. So we can use some of the approaches that Jonathan mentioned, for example, with antecedent changes. And you can implement some fading procedures there. So yes, you can use the kind of protocols and techniques that we discuss with beverages.
It depends on the nature of the problem too. Again, what is your goal, right? So back to assessment, there's articles on utensil and fading. So if kids are only drinking from a bottle, how do we get them to drink from an open cup? So those things are, different than I'm not drinking a liquid and then need to, increase liquid consumption, which Varsovia highlighted. Those fading protocols are useful. Some of the consequence protocols are useful too. So name the presenting problem, whatever your goal might be. There's probably an article out there for all of those antecedent and consequence interventions for that particular problem. But
perfect. Thank you so much. So we've just got 1 minute before 7 p.m. or whatever time it is, in whichever time zone you're in. I just want to take the time to thank you both so much. As you can see, everyone has been riveted and actively engaged throughout the presentation. We had over 100 people with us today from all around the world. And it was at least 15 countries. So I'm absolutely delighted that you were all able to join us tonight. Thank you so much, Dr. Jonathan and Dr. Varsovia, for your wonderful presentation this evening. Everyone will receive an email from me shortly with a copy of the slides that Jonathan and Varsovia had generously agreed to share with us in PDF. And I'll also be sharing those links with you again. You can see the flood of coming in the chat now. So everyone's telling you thank you. This presentation was recorded, so the recording will also be available, and I'll share that link with you all as well in the email. So thank you again, Dr. Jonathan, and thank you, Dr. Varsovia, and I wish you all a very nice day. Thank you so much.
Thank you.